let's get started, I suppose. Can everyone hear me? Okay. Need someone? Great. Does anyone know how to use breakout rooms? No? Yeah, me either. Cool. All right. Well, we'll save that for next time. I can probably figure it out, I'm guessing. Okay. So on Mondays, if we're not taking a test, we'll be talking about how the stuff that we go through in lecture is going to manifest in the real world. So if we're talking about the limbic system, for example, what does it look like for someone to have damage to the limbic system? You know, and what are some typical causes of that? And I think the best way to go through that is, you know, you could see a whole bunch of patients, but that's probably not the most efficient way to do it. I think just going through cases is probably the best way to get you some practice with linking signs and symptoms to area of the nervous system. And that's about the best I can do for you. I can't tell you how to help people, and you don't want me to tell you how to help people. That's not the purpose of this. I'm here to tell you how the nervous system works and what it looks like when it doesn't. So today we're going to start off by kind of looking at everything. So this one is going to be probably the most difficult out of our Mondays, except for the test ones. Those might be a little more difficult for you. But in this case, we're going to be looking at everything. Is everyone able to access the class website? If you're not, send something on the chat. So you should all hopefully be looking at this page on my screen, and you should have access to it as well. There's some notes there. There's, of course, the reading. You've all done that. You've probably looked at my notes. There's some review questions here. And we could go through these if you'd like. I don't think it's going to be as great over Zoom. But I think the better use for these is for you to kind of treat them as homework. So do them on your own time. And if you have questions about it, come see me. But you'll use these to, you know, get ready for the final. So when you're prepping for the final, you should look at the review questions. You'll see there's a mix of stuff like labeling. So you want to know kind of where stuff is. There's some really basic questions. But mostly it's kind of a review of anatomy and your vocabulary, you know, so choroid plexus right here. So just making sure that you know the key words that you might need to know. The other thing you want to look at, these interactive modules are probably useful, but make sure you go through these case reviews, and we're going to go through these in class. So these I definitely want to go through together, so this way we can talk about, you know, what symptoms are jumping out to you and where might the nervous system be damaged to create those symptoms. So we can kind of walk through the rationale for the different choices that are available. And in some cases, you know, multiple things might be correct, and you don't really know until you do further imaging or lab tests. But these are what I want to spend the most of our time working through. So today I'm actually going to give you a little bit of a slideshow, and this won't be typical because for the most part we'll be going through these brain regions in lecture. So you will have had slideshows on them. So I won't need to spend time doing that. So this Monday will be a little less efficient, partly because of we're doing it remotely, and partly because we haven't had class yet. So today's the first day of class. Welcome to class. Are there any questions before we get started? Alrighty. So here are the slides. Okay. Let's not do that. Alrighty. So today's about the nervous system. So we'll go through the whole thing, and then we'll run through those 6 cases and talk about what the answers are and why that makes sense. The first thing I want to do is go over some basic directions so that we all know what is up, what is down, because those terms aren't always the same. I know you're probably sick of hearing this, but it depends. It depends on where we're at in the nervous system, whether up is up. It might not always be up. Hey, thanks, Kyle. I did. I think I set up recording to be automatic. But don't think that comment is going unnoticed. Thank you. So let's have a look at our locations. So on the left there, we have our cardinal directions that are always true. So superior always means up. Inferior always means down. Anterior means toward the front, and posterior means toward your back, so behind you. Those never change, but the ones on the right do change. So dorsal ventral, for example. Sometimes dorsal is up. So sometimes dorsal is superior, sometimes dorsal posterior. And the reason for that is because of our lives as bipeds. So we walk around on 2 legs. And because we walk on 2 legs, our heads can't be facing this way. They need to be facing forward. In order to accommodate that, our nervous system had to tilt as well. So right there at the midbrain, just above the midbrain, it's highlighted here in green. So the midbrain diencephalon junction between the thalamus and the midbrain, there's a twist. So let's see if this works. Does everyone see a little pin moving and maybe something showed up? Okay, beach ball, cool. I tried this before and it didn't work too well. Okay, can everyone see this? All right, someone type into the chat what that is. Thank you. It's a mouse, yeah. Okay. Oh, no, let's not do that one. All right. We'll try this one. All right. That's a feller. So we have mouse, human, 4 legs, 2 legs. If we think about what their nervous system looks like inside there, we're going to have a brain, and there will be a cerebellum behind it, and there's a spinal cord basically running in a straight line. So that's going to be running here, no bend. Over here, we got our spinal cord. It's really hard to draw when you can't actually see what you're drawing. Cerebellum, we got our brain stem. We're coming on up. There's our midbrain. And then rather than having our cerebrum pointed like this, do you ever see any brain look like that? Of course not. There's always a bend to it. It bends forward. It rotates 90 degrees. So that kink in our nervous system means that those older words aren't always consistent with one another. So dorsal is not always up, right? So I would suggest that you try to use superior, inferior, anterior, posterior whenever possible. Okay, here's another example. Could be a dog as well. Again, quadrupeds, they don't have that bend. Bipeds do. So we have some directional terms. We also have 3 planes that we need to think about. And you're probably well familiar with these, but we have our horizontal plane. It's also called axial. So think about the horizon. And if the horizon were to slice through your brain, it would create horizontal planes. Coronal plane, think about a crown, or in this case, a tiara. So if you wear a little tiara, that would create a coronal plane if it were to slice through your brain. And then the sagittal plane, think Sagittarius. So an archer, so you pull back the bowstring, and if you pull back that bowstring and slice through your brain, you'd make a sagittal plane. Most likely you'd be off the center, so we call it a parasagittal plane, but let's not be too picky. So horizontal, coronal, sagittal. You should be able to look at a brain and automatically tell which one you're looking at. So those are our key terms for directions and the planes. We're going to talk about now the outside of the brain, so non-nervous tissue. So the dura, and then we'll get into the CSF, and then we'll talk about nervous tissue in the last two parts. So dura mater means tough mother. This is the tough outer covering of the brain. So in this illustration, we can see the scalp. Below that, we got the skull, and then we finally get to the brain. But of course, before we hit the brain, we're going to have a few layers to go through, and those would be the meninges. The outermost covering is the dura mater, and it has two layers. So near the bone would be the periosteal layer, and the layer that kind of runs with the rest of the meninges would be the meningeal layer. So these names make total sense. Outside of the dura. So if we have our dura mater running here, we got our two layers. Some can reflect inward, that'd be the meningeal layer there. And the periosteal layer is going to run along the skull. Yikes, okay. We have two potential spaces that should not really exist. One is between the skull and the dura, and the other is between the dura and the arachnoid, which we'll get to in just a bit. So epi and subdural spaces. The epidural space is going to be between the skull and the dura, should not exist. There should be no space. They should be right next to each other. There should also be no space between the dura and the arachnoid barrier cells. The reason I say these are potential spaces because they do sometimes exist, and that would be in the case of injury. So if we have damage to a blood vessel, that blood can create a hematoma, and that will create those spaces. So these are potential spaces that could exist, and if you see them, something's wrong. They shouldn't be there. So those spaces will only exist if we have damage to blood vessels, and we get blood leaking out where it shouldn't be. So those dural reflections, there's going to be a few areas where these two layers of dura peel away from each other, and that's so the dura can follow some of these deeper crevices of the brain. So running right down there between the cerebral hemispheres, we have the falx cerebri. So let's just take a look at them. So we've turned the guy to his side and removed everything that mattered, so we don't see a brain here. All we can see is the dura. So there's that sheet of the meningeal layer that folds inward, and that's going to run between the cerebral hemispheres. That creates the falx cerebri. Then there's the tentorium cerebri, or cerebelli, sorry. That's going to run below the cerebrum and above the cerebellum. And then there's the falx cerebelli that's going to run between the cerebellar hemispheres. Now I want you to take note of these sinuses. These are created whenever we create that space between the dural layers. And these are going to act as very low resistance drainage ditches, essentially. So this is a huge space where we can dump fluid into. Because it's so big, the resistance is very low. Get used to hearing that. We're going to talk about resistance quite a bit in this class. And you can try to resist, but it won't work. So in these sinuses, big wide open spaces, very low pressure as a result. So we're going to get one-way movement, as we'll see in just a little bit. Those sinuses are created by the two layers of dura separating from one another. Now, the makeup of the dura mater explains why it's so tough. And what it is a bunch of sheets of collagen. Has anyone ever bought a cheap piece of meat from the supermarket? It was probably cheap because it contained a lot of connective tissue, so a lot of collagen fibers. And the best use for a cheap piece of meat normally is to cook it at a very high temperature. So you'll make a stew out of it, for example. And so you use cheap meat for stews because you want that connective tissue. Collagen turns to gelatin and makes the meat seem like it's moist, even though it's cooked to shit. So the dura mater is made up of a bunch of collagen. And what you'll notice in this illustration here, after I point it out, you'll notice it. Here's a sheet running in this direction. So it's kind of running, here's the grain. Now there's another sheet right below it. I want you to notice the grain is running this way. So we're essentially weaving together these sheets of collagen. So we have strength in all directions. And if you ever try to pull on a dura mater, you're not going to pull it apart. That's why it's called the tough mother. And it's tough because it's mostly collagen. It also has some blood vessels running through it, as well as some innervation as well. So there's a bunch of collagen, there's some blood vessels, and there's some nerve fibers. So we're going to have meningeal arteries and veins kind of running on the surface there, so we can bring blood and keep the cells alive that make up the dura. And we can potentially break them, and that's why we can create those epidural spaces, because we have, in this case, the middle meningeal artery kind of running along the outside surface. If this thing ruptures, blood's going to spill out and create the epidural space. The innervation of the dura only occurs in the brain. So we have a dura mater that covers the brain, but it's also going to run down along the spinal cord as well. But we don't have innervation of the spinal dura mater, and we'll get to that in just a little bit. The innervation is going to come from mostly our cranial nerves. So all this part that you see here, this big old part that has the middle meningeal artery running on it, that's all innervated by the trigeminal nerve, so cranial nerve 5. All the lower parts are going to be innervated by the glossopharyngeal and vagus nerve, so 9 and 10, as well as the upper cervical nerves as well. Whenever you have irritation of the dura, you get headache. Irritation can come from infection. It could be just inflammatory cytokines. It could also be swelling. So swelling that pushes on the dura will lead to headache, and that's why increased intracranial pressure will create headache. It's pushing on the dura. It has nothing to do with the brain. All right, so there's our skull. We don't care about it. We got our dura here, periosteal, meningeal. Now we're getting down into the arachnoid. So dura, then the arachnoid. The arachnoid is going to have two parts, kind of like the dura has two parts, the periosteal and meningeal layers. The arachnoid is going to have the arachnoid barrier cells, and those are sitting right on the surface. So between the dura and the subarachnoid space, we have the barrier cells, and they're exactly what they sound like. They're going to create a diffusion barrier so that any of the stuff floating around in the dura can't make it into the brain. We don't really have a blood-brain barrier there in the dura, so we want to make sure there's no diffusion of nasty stuff into the cerebrospinal fluid. And the cerebrospinal fluid is going to be in this big subarachnoid space. So rather than having barrier cells, we have these arachnoid trabeculae. These are cells that are going to create space. And we're going to fill that space with blood vessels and cerebrospinal fluid. When you hear arachnoid, what you need to be thinking about is cerebrospinal fluid and blood vessels. That's all it is. The pia mater is the last of our meninges. What just happened? Okay, yeah, we're good. So we got dura mater, arachnoid mater, pia mater. So the pia mater ain't shit. It's really easy to break. You can try to keep it intact, but you'll fail. So unlike the dura mater that's very tough and you can pull on it, if you look at the pia mater wrong, it just falls apart. Very delicate. And what it's going to do is right along the surface of the brain. I don't really know what its function is other than to get in the way during a dissection. It doesn't really stop diffusion. It just kind of rides along the surface. It's just extra skin there. I suppose maybe it helps restrict the movement of fluid to some degree so the brain stays a little more moist, but that's speculation. The subpial space is a very, very small space, but it does exist. And that's just kind of an area for CSF to float into. There's not much to talk about with the pia mater. We do need to talk about the glial limitans, though. So now at this point, we are in the brain. Glial limitans. So it's something from glia that's going to limit something. That's what the name is telling us. So the glia are limiting something. The glia we're talking about here would be astrocytes. And what we're limiting is diffusion. So that pia mater is going to follow blood vessels for some distance as they move into the brain. Eventually the pia will disappear. And all we're going to have surrounding our blood vessels would be the glial limitans. So those in-foot processes that surround blood vessels, kind of at the very surface of the brain, even as you move inward, what these do is restrict diffusion. So when stuff comes out of the blood, it's going to have to move into astrocytes and be transported to neurons. So there's indirect access to blood for neurons. And we should remember that blood is toxic to neurons, so we want to have many degrees of separation. We have a blood-brain barrier, and then we have the glial limitans. So in-foot processes around those blood vessels. And what they're going to do is prevent stuff from moving around unless astrocytes can pick it up. So here's an actual image showing you restriction of diffusion. Here's just a cross-section of a blood vessel. Here's another one. All right, so we're just cutting through blood vessels, and then we use antibodies and dyes to make these pretty pictures. What I want you to notice in part C here, this pretty picture, notice this cell right here. Here's an astrocyte that has its in-foot process coming up and hitting the blood vessel. Good question, Marie. We'll get to that in just a little bit. So that in-foot process is going to surround what we call the perivascular space. That's exactly what it sounds like. It's the space around blood vessels. It's filled with cerebrospinal fluid. So when the blood vessel penetrates the brain, so here's our brain, and we're going to put let's get us a blood vessel running into the brain. Let's say we have there we go. All right. So we're heading on down. Here's our blood vessel, and we've penetrated the brain. Those blood vessels run in the subarachnoid space. So does CSF. So while the blood vessel is penetrating into the brain, let's see if I can get some CSF in here. CSF is going to ride along next to it in this space right next to the blood vessels. That's the perivascular space. So we have a little bit of fluid for stuff to diffuse into from the blood. Now right there at the surface of the brain, that's where we have our glial limitans. So here's an astrocyte, and it's going to put an in-foot process out to surround that blood vessel. Imagine this wrapping in 3D. So it's going to wrap around there. There's a bunch of other astrocytes lining the entire length of this blood vessel. So surrounding the blood vessel and the perivascular space, we have those in-foot processes. That's what this picture shows us. So here we can see blood vessel. Here's the inside of it. That's the lumen. Here's the epithelial cell that's making up the blood vessel, and here's the space around it, the perivascular space. Here's our in-foot process from an astrocyte. So we're going to restrict diffusion. If something exits the blood, it must be picked up by astrocytes in order to make it to a neuron. This is just another layer of protection. The first layer of protection is the blood-brain barrier. And that is a series of tight junctions between epithelial cells of the blood vessel. So stuff can't just leak out through the space between epithelial cells. So they're held together very tightly. You don't see this outside the blood. You have kind of loose capillary beds, so you can get diffusion, but we don't want that in the brain. So tight junctions make up the blood-brain barrier. When things leave the blood vessel, then we have our glia limitans. That's going to also serve as a diffusion barrier. So anything that gets out, like in this case, we're looking at ovalbumin. So it's just an egg protein that's soluble, but you shouldn't find it floating around. So they injected a fluorescent form of this protein, waited a while, cut open the brain and had a look. And what they found is that this isn't just leaking out everywhere, you'll notice, it's restricted into astrocytes, because in order to get out of the blood where they injected it and into the nervous system, you have to cross the blood-brain barrier and then be picked up by astrocytes. And at that point, you're in the brain, and so are we. Just a quick review here, going from the skull down into the brain, that'd be our glial limitans there. We're going to have our dura, which has 2 layers. There's 2 potential spaces. Notice the asterisk there. So 2 layers of the dura. That's the tough mother, tough outer covering. So it's going to provide some protection so we don't bump the brain into the skull. The arachnoid mater is going to have the barrier cells that are going to restrict diffusion, and the subarachnoid space that allows movement of CSF. It's going to also hold blood vessels. Pia mater ain't shit. Subpial space, think of that as kind of the perivascular space. So CSF can diffuse into that and then run along blood vessels. And then we have our glial limitans that's going to surround blood vessels and make sure we don't let toxic stuff flow into the brain. Okay, so that subarachnoid space is going to be filled with CSF, cerebrospinal fluid. So that's the fluid in our brain and spinal cord, as the name suggests. We're going to make that in the ventricles. It's going to flow throughout our ventricles into the subarachnoid space, and then we're going to pick it up in the sinuses. So here's the general flow. We're going to create CSF in these specialized structures called the choroid plexus. We're going to see that in every ventricle, whether it's our 2 lateral ventricles, the 3rd ventricle, or the 4th ventricle. So that's what makes CSF. There's a bunch of blood vessels in the choroid plexus, so it has good blood supply. It can pull out the fluid that's going to make up CSF, and then we're going to circulate it through our ventricles. As we move through the ventricles, we will eventually get dumped out into the subarachnoid space. So you can think of it starting in the lateral ventricles. We're going to look at this cartoon view here, and then we'll look at an actual view of the ventricles. We're going to go from lateral ventricles into the 3rd ventricle through a space called the interventricular foramen, so between the ventricles. From the 3rd ventricle to the 4th ventricle via the cerebral aqueduct. And this is a good one to know. It runs through the midbrain, and it's a very fine opening, very high resistance, and easy to plug up. From the 4th ventricle, we have a few options. So we can continue along. It's going to narrow into an opening we call the obex and then become the central canal of the spinal cord, or we can exit into the subarachnoid space. We can go through the hole in the middle, so the foramen of Magendie, M for median, M for Magendie, and it's luckily for the lateral ones, the foramina of Luschka, L for lateral. So it works out. Pointless to know, but it does work out. Once we're in the subarachnoid space, then we'll float around and we'll get absorbed in the sinuses there. So let's take a look at the choroid plexus. This is where it all starts. Here we have what we call ependymal cells. These are the glia that make cerebrospinal fluid. They're going to line the ventricles, and they're going to beat their little cilia so that they move CSF. So we actually get a flow of CSF, and you can visualize this. So there's actual flow of CSF through the ventricles because 2 things. Higher pressure, because we're making CSF in a confined space. So that pressure difference between our ventricles and the sinuses will push the CSF toward the sinus. And then the ependymal cells are going to aid that by creating little currents. The choroid plexus, shown in part B here, you'll just notice is a lot redder. So it's full of blood. So we have those blood vessels, that's the BV right there, surrounded by our ependymal cells. So they're going to pull out fluid and make CSF. Each ventricle has its own little choroid plexus there. So we're always making CSF. Here's a slightly better view of the ventricles. So we're looking at a side view here. So sagittal, I suppose. We have our lateral ventricles. These are going to have kind of a C shape. They're going to come together. The third ventricle, that's going to be between our two thalamic hemispheres. So third ventricle, thalamus. The lateral ventricles, that's going to hit the cerebral cortex. The cerebral aqueduct is in the midbrain. And then our fourth ventricle is going to be behind the pons in front of the cerebellum. Here it is head on. Here we can see our exits. We got our foramina of Luschka here, and then Magendie is back behind there. We can't really see it. And then here it is in 3D, so it's going to turn around. This way you can see all the different ventricles. And what I'd like you to notice, when it spins back around here, take a look at that cerebral aqueduct right there in the center. Notice that this is the thinnest part. So if we're going to obstruct CSF flow, this is the most likely candidate. Yes, think of the glial limitans as the last line of defense. Okay, so once we make it into the subarachnoid space, there's a few large areas that we call the subarachnoid cisterns. You can see them here in this illustration. So some of them are going to be, this is going to be midbrain spinal cord. Because up in the cerebrum, we have our lateral ventricles. So we don't really need these. So midbrain, we're going to have kind of three different cisterns that are going to make a ring around the midbrain. No pocket full of rosies, but in the back, we got our quadrigeminal cistern. So this is right behind the quadrigeminal plate. So the name makes sense if you know about the quadrigeminal plate, and if you don't, it doesn't. So this will be your superior and inferior colliculi. You've probably heard of those before. So it makes four little bumps. That's on the back of the midbrain, and that's where the quadrigeminal cistern is. On the front, we have the interpeduncular cistern. So this is between the cerebral peduncles. The cerebral peduncles would be the corticospinal tract as it runs in the midbrain. So between those two major motor pathways, we have a space that's filled with CSF. And since it's between the peduncles, we call it the interpeduncular space. And then the ambient cisterns are going to connect those two together. So we have a continuous ring of CSF. You know, you'll notice that CSF is surrounding the entire outside and inside of the nervous system. And this way it acts as a cushion, so we don't get any compression. There's some hindbrain cisterns down here further below. So behind the medulla and under the cerebellum, we have the cisterna magna. And then in front of the pons, we have the prepontine cistern, or the cisterna pontis. The one that actually matters would be the lumbar cistern down at the bottom. The reason why this one is so important is because we use it to access the CSF. So if we want to sample someone's cerebrospinal fluid, we're going to tap into the lumbar cistern. The reason this is a great option is that there's not a lot of nervous tissue around. There are definitely some spinal roots running down in there in the form of the cauda equina, but you'll probably recall from several minutes ago when I said that the dura was only innervated at the brain. So if we were to try to access any of these other cisterns, you'd feel it, but you don't really feel it down here. You'll feel pressure, of course. You'll feel it when you're going through the skin to access it, but the actual lumbar puncture is going to be painless because there's no innervation of the dura. So it's a relatively pain-free and also relatively low-risk way of accessing cerebrospinal fluid. So we can collect in these cisterns, but inevitably we're going to have to leave because we're always making CSF. And the way that we're going to leave is through things called arachnoid granulations. So remember, we're in the subarachnoid space. So we're in the arachnoid mater at this point. The arachnoid granulations are these little protrusions of the arachnoid mater into either a sinus or a vein. Now, when you're in the brain, you're going to be punching into the sinuses. When you're in the spinal cord, you're going to hit a vein. The purpose here is to get the fluid out. So we're always making CSF. This way we have fresh CSF with the correct balance of ions. It's got glucose. It's got what neurons crave. And after it's been used up, we want to get rid of it. So the reabsorption of CSF is going to take place in these low pressure sinuses. That's going to create a unidirectional flow, so we don't get backflow of CSF, we don't have fluid building up, and we don't have hydrocephalus. Here's hydrocephalus. So this is what happens if we don't have proper movement of CSF. And that improper movement is the most likely cause of hydrocephalus. Now, it could be that you have a change in the amount of CSF that's being produced, but this is fairly rare. You'd have to have some sort of tumor, a functional tumor in the choroid plexus. It happens, but it's very rare. So almost everyone's going to be making about half a liter of CSF every day. Almost everyone's going to be able to hold about 125 mils, so about a quarter of that. So we turn over our CSF about 4 times every day. If we have obstructions in the ventricular system, we're going to get CSF buildup, and we're going to have an increase in intracranial pressure. And that's what we're seeing in this bottom image here. I tried to select a fairly consistent slice. Here's the lateral ventricles in a healthy brain. Notice we got one down here. Remember, it's C-shaped. So we're looking at the bottom of the C right down here in the temporal lobes, and then here's the top of the C. Here it is. Here's the bottom of the C. Here's the top of the C in the case of hydrocephalus. Most commonly, this is going to be caused by some sort of growth or perhaps a malformation in the midbrain. That cerebral aqueduct. We should see a little tiny hole here, but we don't. Instead, we see an arrow, and the arrow always tells you when something is wrong. So this is a CT scan showing us enlarged ventricles, and that's because we're not seeing a cerebral aqueduct here. Whenever we have compression of the cerebral aqueduct, the choroid plexus in the lateral ventricles and third ventricles still continues to make CSF, but it has nowhere to go. And that's when you see hydrocephalus. It'll eventually create enough pressure to squeeze some through, but you're going to have enlarged ventricles and increase in intracranial pressure and the accompanying signs. It could also be because of impaired reabsorption, but again, this is rare. So you could have some sort of increase in sinus pressure, or you could have damage to those arachnoid granulations. Most commonly, though, it's going to be obstruction of the cerebral aqueduct. Okay, and finally, we are into nervous tissue. So just 2 quick points here, and we'll go through the cases. I just want to give you an overview of the nervous system. I like to think of it as many pairs working together. So the first pair that we have would be central and peripheral. Central would be brain and spinal cord, hey, another pair. And then the peripheral nervous system, we're going to have our somatic and autonomic nervous systems, another pair. And they'll both have sensory and motor functions, another pair. The autonomic will have parasympathetic and sympathetic, another pair. And both of those will have preganglionic and postganglionic neurons, again, a pair. So, central nervous system, brain and spinal cord. Both of these are going to have processing that goes on. So they're going to have patterns built in so that whenever you have some sort of input, you'll get some sort of output. In the spinal cord, there'll be very simple reflexes. In the brain, they will be far more elaborate reflexes, or as some people like to think of it, conscious behavior. It's debatable. But processing and storage is going to be in the central nervous system. The peripheral nervous system is all about connections, like these. So some are just going to be a simple cable. So run from here to here, but we also need adapters as well, so that we can translate things like pressure into electrical activity. or things like light into electrical activity. So you get the point. In the different divisions of the central nervous system, we're going to see gray matter, white matter, and then we'll see CSF. So CSF is going to be everywhere, acting as a cushion, acting as a solvent that we can move ions and glucose and gases around in. The gray matter is going to be made up of everything but myelin. Okay, so cell bodies, dendrites, unmyelinated axons, that's all going to be in the gray matter. The white matter is going to have just myelinated axons. That's why it looks white. So the fat makes it look white. And what I want you to notice here is that as we move from high to low, so in the cerebral hemispheres here, so in the cerebrum, in the brainstem, and in the spinal cord, I want you to notice the change in the location of gray and white matter. Notice gray matter all on the outside in the cerebral cortex. That's where the neurons live. That's where the magic happens. That's where we create perceptions. That's where we plan our actions. And the neurons are the ones doing that. And you'll notice the white matter is below them. So they're communicating downward. When we get to the midbrain, when we get to the brainstem, you'll notice there's an intermixing of gray matter. So we'll get some nuclei. We'll have some neurons living in here, but there's white matter kind of throughout. And when we get down to the spinal cord, all the neurons are living inside, because the purpose of the spinal cord is to communicate outward and to relay upward and downward. So the most important function of the spinal cord is to move electrical activity around. So all the white matter is on the outside, so that when sensory information comes in, for example, it just heads straight up your dorsal columns if it's not painful. Those descending axons of the cortical spinal tract, they're going to run down the side and then eventually come in. But now our neurons live inside, so we're flipping the gray matter and white matter, and that has to do with their function. The brain is there to kind of store information, make plans, make sense of things, and the spinal cord is kind of more of a relay. That's a little bit of an oversimplification, but it's okay. So the relays between the central nervous system and the rest of the body are going to come in the form of nerves. So they're bundles of axons and other stuff too. Of course, we have to have blood there. There's glia, there's connective tissue to hold it all together, but largely they're bundles of axons. We have 12 cranial nerves that we'll talk about. We'll talk about spinal nerves kind of generally. We'll hit a few key peripheral nerves, but there's 31 pairs of spinal nerves that are going to innervate the body. The cranial nerves are going to hit the face, the eyes. We'll hit some viscera as well. Those are going to emerge from the brainstem. All the spinal nerves will emerge from the spinal cord. So here we can see our cranial nerves, most of them anyway. We don't see cranial nerve 1 because it's further up. We'll see it later on in the class though. But going from top to bottom, you're going to go from 2 to 12. It kind of goes down to 11 and then back up to 12 for historical reasons, but pretty much an orderly movement from top to bottom. You're going to increase cranial nerve number. What I'd like you to notice is that the midbrain here is going to have cranial nerves 3 and 4 come off of it. It's going to be very important for controlling the eyes as a result. Now the spinal nerves are of course going to come off the spinal cord, as the name suggests, and they're going to exit through the intervertebral foramen. So they're going to, here's our vertebral column running around. So we have our body up in front of, and then our arches behind the spinal cord, and there's a space that the ventral and dorsal roots can move through. And those will exit and innervate the rest of the body. In areas where we have limbs, we're going to see these brachial plexus here and lumbosacral plexus down here, so we can innervate the arms and legs. Not so much in the thoracic spine. That's fairly straightforward. The peripheral nervous system that's coming off of our spinal cord, we can think of as being somatic, that is under conscious control and conscious awareness. So your ability to feel and move, that would be your somatic nervous system. And so that's going to innervate skeletal muscles, and it's going to innervate your skin, joints, and muscles for sensation. The autonomic nervous system is also going to come off of the brainstem as well as the spinal cord. Sympathetic right here in the thoracic and upper lumbar region, and then the sacral coming is going to give rise to the parasympathetic portion, at least the bottom of it. So we have a bunch of these spinal nerves coming off, and those are going to create our dermatomes and myotomes. So we have kind of this orderly arrangement as you move down your spinal cord. You're going to go from the top of your body down to the bottom. Now there's kind of a weird wraparound in the legs. We're going to go down the front and then hit the back and hit the anus at the end. This has to do, again, with our change in lifestyle. So we are bipeds, but if you were to look at this in a quadruped, it makes sense to go from head and hit the anus last. And yes, of course, you're going to wrap around the front and then hit the back of the legs. That's the order of the body. We just don't think of it that way because of how our body's arranged. So it makes sense for quadrupeds, and that's how the nervous system, well, that's where it was made first, in quadrupeds. So we're just looking at kind of some leftovers from an old model. But we've remodeled our body. Now we stand on two legs. You're probably well familiar with the dermatomes, myotomes. That's just showing you the sensory and motor component of spinal nerves. And it makes good sense. There's an orderly arrangement. You get kind of these bands of innervation. The dorsal nerve roots are going to contain the sensory information, and the ventral nerve roots are going to contain the motor information. So here's our spinal cord up here. And again, we're going to go through all of this many times in this class, so it's going to seem like a lot in this first one. The anterior horn or the ventral horn, that's where we have our lower motor neurons. They're going to come out in the ventral roots, and they'll eventually combine with the dorsal root. Here's the dorsal root ganglion where the sensory nerves live. Once they come together, they're now a spinal nerve. Mixed sensory and motor components. Also mixed with autonomic components as well, if we're in the correct location. So if we're in the thoracic, so T1 to L3 or S2 through 4, we're also going to have some autonomic components. Those are going to arise from what we call the lateral horn. So notice this little outpouch right here. Not so much here, but in the thoracic region, you're going to see well-defined lateral horns. The anterior horn will actually be a lot smaller because we have fewer lower motor neurons because we don't have limbs right here. So we have fewer muscles to innervate, but now we have our autonomic component to consider. So from the lateral horn, we're going to have axons coming out. They'll do a quick turnaround if it's sympathetic and create those postganglionic fibers. So we have another pair, preganglionic that lives in the central nervous system, and postganglionic that lives outside the central nervous system in ganglia. And a ganglion is just a collection of neurons outside the central nervous system. For the sympathetic component, those ganglia are going to be fairly close to the thoracic and lumbar spine. Most of them are going to be in the paravertebral column or the sympathetic chain ganglia. Some will be above that in the prevertebral ganglia. So you'll find those along blood vessels. And then we have the adrenal gland that's going to act as a specialized postganglionic neuron. Rather than having an axon, it's going to dump its neurotransmitter and hormone into the blood supply. But most postganglionic neurons are going to be right there next to the spinal cord. This is in contrast with the parasympathetic nervous system, where the postganglionic neurons are going to be on or very close to their end target organs. The preganglionic neurons are going to make a sandwich here. So we have the top piece of bread is the brainstem. The bottom is going to be the sacral spinal cord. That's for our parasympathetic neurons. And the meat is right there in the thoracic and upper lumbar spine. That's the sympathetic. We'll talk about what these do to their target organs later on. For sympathetic, think fight or flight. And for parasympathetic, think rest and digest. And there's a list of them there. You'll notice they do opposite things. They're going to act as a pair. One is the gas, the other is the brake. This way you have excellent regulation of the end target organs. You can turn them on, turn them off. Now we're just going to talk about the entire brain in about 3 slides. So we should cover it pretty well. And then we'll get into our cases. We're going to go from bottom to top here. So very simple, but vital. That's the brainstem. So starting at the bottom, we have the medulla. So just above the spinal cord, you have the medulla. And here you should be thinking vital functions. So breathing, heart rate, blood pressure, things that are critical to regulate if you want to remain alive. The medulla is also going to control some kind of reflexive components of behavior. We'll talk about those later on, but you don't have conscious control over this. We don't get conscious control over stuff until we get up into the cerebrum up here. That'll be, I think, 2 slides from now. Moving on up, we have the pons. So the pons is kind of like the regulator of the medulla. So it's going to have pattern generators that help control what the medulla does. So it's going to hit many of the same tasks. So breathing, swallowing. It's going to help regulate everything that the medulla does. And it's also going to be an important middleman between cortex and cerebellum. So even bigger than the corticospinal tract is the corticopontocerebellar tract. It's much larger. I think it's somewhere about 40 times larger than the corticospinal tract. And the reason that it's so big is that if you want to make a movement, you'd like it to be coordinated, and that's the purpose of the cerebellum, to coordinate our movements and make sure we can smoothly do multi-joint movements without overshooting and hitting ourselves or missing the timing of different joints so we don't actually line it up properly. So when you hear cerebellum, you should think it's all about coordinating movements. That's a vast oversimplification, but it's a big part of what it does. That movement could be a gross movement, like just reaching out and touching something, or it could be a more delicate movement like speech. So you'll see slurred speech with cerebellar damage as well. Running in the pons, medulla, and midbrain, we also have important neuromodulatory neurons. So not your glutamate, GABA, glycine, but special ones like norepinephrine, serotonin, and dopamine. They only live here in the brainstem, and they innervate the rest of the brain. Norepinephrine, definitely in the pons. Serotonin is going to be in the pons and medulla, in the raphe nuclei, and in the midbrain, dopamine. And dopamine is critical if you'd like to move and feel good. The midbrain is also key for consciousness because the ascending arousal system, so those fibers that come from the brainstem that keep the cortex awake, have to pass through the midbrain. So when you have damage to the midbrain, you'll sometimes see drowsiness or coma can also occur. You'll also see impaired eye movements. That's key. That's going to tell you midbrain damage because arising from the midbrain, we have our oculomotor and trochlear nerve. The only eye muscle that we're not going to hit is the lateral rectus. That's going to come from the abducens a little further down. So the oculomotor nerve is going to provide parasympathetic input. So it's going to help constrict our pupils. So when you have damage there, what you'll see is a blown pupil. So it'll be big regardless of how much light you hit on there. If you have midbrain damage, you can't provide parasympathetic input and restrict that pupil. So a blown pupil with loss of consciousness, midbrain, definitely. It's hard to look at eye movements in people who have lost consciousness, so that's why you'll look at the pupils. Moving on up, we're in the thalamus. All I want you to think right now is grand central station. The thalamus is the sensory relay. Almost nothing makes it to the cortex without passing through the thalamus first. And the cortex and thalamus continue to talk with one another throughout the day. They are a unit. I guess this would be another pair. Think of the thalamus and cortex as being intimately connected. And the cortex is going to pass motor plans to the thalamus as well, and it's going to check it, of course, through the basal ganglia. So they're going to work as a team. So the thalamus is often thought of as a middleman, but it's far more than that. The hypothalamus is a little bit anterior and inferior to the thalamus. And for this, we need to be thinking about circadian rhythms, so sleep-wake cycles, as well as neuroendocrine function. The hypothalamus and pituitary, another pair, are going to work together to release hormones. They can affect growth, sexual maturation, stress, a variety of things. But when you see problems with neuroendocrine signaling, you should be thinking hypothalamus, pituitary. That should be an immediate knee-jerk reaction. And finally, we have the forebrain, or the cerebrum. Below the surface, we have the basal ganglia. They are shown here. Here's one half of them. So there's our thalamus. This is where they're going to communicate to say whether something's a good idea, because that's the purpose of the basal ganglia, to select appropriate actions. We will go through the basal ganglia later on. We'll learn about the nuclei and how they talk to each other. That's their function. So there's the striatum, which is made up of the caudate and putamen right here. Then we have our globus pallidus. There's a subthalamic nucleus in there somewhere. They'll communicate with the thalamus. A lot more on that later, but basal ganglia, action selection. That's what it's all about. Limbic system, that's going to be all about emotion, memory, and drive. So we're going to walk through one of the circuits right here. So this is a loop. You could start anywhere. So we're in the cortex, the cingulate cortex here. We're going to go into the rest of the limbic system. That's going to be our parahippocampal gyrus and entorhinal cortex. Then we enter the hippocampus. You've probably heard of the hippocampus before. When you hear hippocampus, you should think memory. So if you can remember the hippocampus, thank your hippocampus for that. We're going to follow that fornix around and we'll eventually hit the mammillary bodies. We're back in the diencephalon there. And then we'll head back on up to the cortex via the we'll hit the thalamus first, then the cortex. Nothing goes straight to the cortex. We always go through the thalamus. And we've completed the loop. We'll go through this later. This is just to highlight some of the brain regions that are there. So this is kind of more in the center of the cerebrum there. And on the outside, that's where we have the cortex, that wrinkly outer covering. Cortex just means bark. So it kind of looks like bark, I suppose. It's wrinkly so that we can increase surface area. This way we have a whole lot more cortex without necessarily increasing brain volume. So if it were just a smooth cortex, we'd only have as much surface area as our skull. But by making it wrinkly, we have a whole lot more surface area. And that allows us to do more magical stuff, like learn languages and create art, or just plan a simple action like this. And you'll notice I've learned to keep my pinky up. That's because of the magic of the cortex. We're going to go through the different zones of the cortex. For the most part, motors in the front, sensories in the back. We've got our primary somatosensory cortex here and our primary motor cortex right in front of it. You should know these. The precentral gyrus, motor, post-central, so behind it, sensory. And these are going to talk to each other, make predictions about what should I feel based on that movement. Should I feel a table? Yes, and I was right. We also have our primary visual cortex in the back. Between those two areas, we will think about the rest of the world and our body together. So we'll have a spatial map between there where we think about where we are, where the rest of the world is. Where's my water? Oh yeah, I remember it's over there. I'm not going to look. See, I didn't even look. And that's because I have a map. I'm combining information about my body and the rest of the world. So as you move between different functional areas of the cortex, their powers combine. Rather than making Captain Planet, it's going to make, in this case, a map of the world. But it can make a whole bunch of things. So for example, we have our auditory cortex here, visual cortex here. Between those, we start to ascribe names to objects. So down here in the temporal lobes, we'll learn people's faces, or that this is called a note card. But that's where the magic happens. And I believe, oh, okay, there's a map, sorry. We store memories, and I did not store memory of this animation, sorry about that. So there's an orderly arrangement in our spinal cord. So we create our dermatomes and myotomes. There's also an orderly arrangement in the cortex. So, for example, the face is near the hands, is near the arm, is near the body, is near the legs, near the foot. So we have to turn our body into a strip, and that's what it did, kind of like this. We go from face to hands to arms to body to the legs and feet. And it's pretty similar over here in the sensory homunculus. We have the genitals added, but pretty similar right there. It's an orderly arrangement. Things make sense. Parts of the face that are next to other parts of the face are next to each other in the cortex. And that is all I have to say about that. Are there any questions? Okay. If they come up, just drop them in the chat and I'll get to those. What I would like us to do is go through these cases, and what I would have us do in class is you talk to your neighbors and you know, you discuss the case and whatnot. I don't know how breakout rooms work, so you know what? I'm just gonna look this up. It can't be that hard. Hopefully I didn't have to do this first. All righty. Breakout room in the meeting tab. Oh boy. This meeting. I don't see this. Here we go. What the fuck is this? Account management. God damn it. Maybe I won't do this. Isn't this painful? All right, yeah, fuck it. We're not gonna do this. All right, my bad. I was not prepared. I'm so sorry. So what we'll do instead, let's just go through the cases and we'll pretend like you had some wonderful discussion. And I'll just edit this part out. So if you click on these, it should open up a big window so you can actually read what's going on, yeah? And I do believe many of you have already answered, but not everyone, that's totally fine. So let's walk through this. We got an 11-year-old male admitted progressive headache, nausea, and vomiting. All right, so immediately you should be thinking about something. What's coming to mind when we hear progressive headache, nausea, and vomiting?
Increasing intracranial pressure.
Parker Rose, thank you very much. Yeah. Is there anything else on here that might be consistent with an increase in intracranial pressure? What the hell is papillary edema?
Is that fluid by the eyes?
Yeah, pretty much, right? So, so behind the eyeball, in the optic nerve, there's a buildup of pressure, and what it's doing is pushing out the optic disc. Dead giveaway that we have an increase in intracranial pressure. So we should already be thinking increase in intracranial pressure. And that's clearly pushing on the facial nerve as well. We're getting a little facial nerve palsy. Let's see, he'd been investigated at home and it was diagnosed with arteriovenous malformation located in the perimesencephalic region. Okay. Think about where the perimesencephalic region should be. Go ahead and just throw your answers in, and we'll wait for this response number to jump up somewhere, I don't know, around 40. I want you to go ahead and get your answers in there. So think about what perimesencephalic would mean. We're going to look at panel B and think, what am I seeing signs of? And then what has caused this? So let's take a few minutes, and once this response number jumps up, we'll have a look. All right, we're just going to go ahead and move along. I don't know. I wish I had more patience. So who wants to run me through their thought for what perimesencephalic is going to mean?
It should be around the midbrain because the
There you go.
mesencephalon in development.
Nice, nice. So the mesencephalon is the midbrain. So near the midbrain. Okay. Increase in intracranial pressure around the midbrain. Okay, let's have a look at panel B. What are we seeing signs of? Let's have a look. Hard to say cortical atrophy. There's a surprising robustness to the brain for going through hydrocephalus. So if you correct it quickly, you can be all right. We'll talk about how we corrected this in just a bit. Really what we're seeing here is hydrocephalus. That's pretty clear. This is the most striking feature. So B, this is a before and after they put in an intraventricular catheter. So we're getting our answers if we read all this. So big old ventricles, damage around the midbrain. Condition was most likely caused by, excellent, obstruction of the cerebral aqueduct. Now the intracranial pressure is the consequence rather than the cause. I doubt it that they were just born with large lateral ventricles. The reason being when we put a catheter in, they go back to normal size. So it's not a congenital enlargement. Instead, obstruction of the cerebral aqueduct. And here you can see the catheter. So the best way to fix this is to stick a catheter in. We're going to pull fluid out and we're going to dump it in the abdomen and let it get reabsorbed there. This way we have a means for the fluid to escape. And when we relieve the pressure, often this will open up the cerebral aqueduct. If it doesn't, leave the catheter in. So that's how we're going to correct that. So these cases, I think, are set up to give you feedback. If you got it incorrect, it should tell you some feedback. Let me know if that's working. Okay, we got another case here. And again, so these cases are going to seem maybe a little more difficult than most because we're talking about the entire nervous system, so anything's possible. Try to kind of bias it toward, the meninges and CSF, but later on, whenever we go through specific brain regions, it's a lot more focused. Okay, so we got ourselves here, 24-year-old female, presented because of partial seizures in the right upper and lower limbs. Let's see here. Alert, awake, oriented, no head injury, cranial nerves are intact. Again, we got right weakness. We also have some sensory abnormalities. No history of head trauma, but we have head banging at punk rock concerts. 17 and 3 days before. Let's see, she had a fall back when she was 11 months old. Here's the MRI and CT. Again, when you have arrows, not good. So we have CT here. We have a T1 weighted MRI, T2. Hopefully remember this will show us areas of inflammation if we have any. And then we got a follow-up CT, because why not? We're just asking you to pick out the plane here. This one should be straightforward. And then usually what I'm going to ask you is where is the problem and what is the problem? So most likely, what is she suffering from? Go ahead and pick that one. And then which side are we dealing with? And then there's an outcome. When possible, I'm going to give you the outcome of these cases. They don't always give it. And I will try to pick cases where things turn out reasonably well.
Dr. Pitt,
Yes.
I just had a question on the brain damage side, and this is probably stupid, but with the arrows, wouldn't it be pointing to the damage on the right side?
It is pointing to damage on the right side of the image.
So is that opposite in the head? Because the correct answer is left. So is the picture like flipped?
So, yeah, and so this is a good question. So whenever you see these images of the brain, what you have to keep in mind is that they are flipped. So it's like the patient is looking at you. You can also tell which side it is by looking at which part of the body is affected. So which limbs, the right or the left? Anyone?
The right.
Yeah, the right upper and lower limbs. So which side of the brain is going to control our right limbs?
The left.
Thank you. Yeah, exactly. So that'll be a giveaway. And I'm so glad you asked that. I was going to point that out. So I want us to get this straight right off the bat. These are always flipped. It's like the patient is looking at you. Okay, cool. We got a lot of responses in here. So let's have a look. So these images, obviously we're doing a slice through the brain like this. Sometimes you hear it called axial. It's also called horizontal. Let's see. Okay, so what is she suffering from? Let's see what we've picked here. Okay. All right, so meningitis. We would think that if maybe she were immune compromised or she had been sick recently. There's really no signs of infection. I wouldn't consider meningitis. I would also take a look at these images. Okay, so T2 weighted MRI. If we have meningitis, we should have inflammation, and thus our meninges should be lighting up, but they're not. We really see it more in the T1 weighted, not so much over here, and that's suggesting instead that we probably have some sort of fluid buildup. Subdermal hematoma is a much better choice here, and this is a true case. So some pretty severe head banging led to a subdermal hematoma. The brain damage occurred on the right side of the picture, that's the left side. And she stopped head banging. She got a benzo, everything was fine. CT looked good at 1 month follow-up. So everyone was okay and they all lived happily ever after. And I'll try to find those cases for you when possible. All right, let's move on to this one. So we have a 62-year-old bank executive. So an older person here, mild difficulty running. It progressed to left leg weakness, then some headaches. Those worsened, so we have progressive symptoms in an older patient. That should be a pretty big giveaway here. It looks like we have some facial weakness, so the nasolabial fold is decreased. And we have a little bit of weakness in the left triceps and left leg. Unsuccessful treatments, symptoms worsened. Eventually became hemiplegic on the left, unresponsive to deep pain, and a blown right pupil. Patient stopped breathing the next day. So what are we thinking here? We'll wait a little bit for some responses to come in, but think about what could cause this. You always want to consider the patient. Okay, so how old are they? What do they have a history of? We're not really getting much history here, but we do see that he's old and we do see progressive symptoms. So let's see what we're thinking. Okay, good. So most of us are keying in on brain tumor here. Demyelinating disease, all right, that could be. Right, because it's progressive, and demyelinating disease should be progressive as well. It can be waxing and waning, but progressive could be true there. And especially seeing, that you're affecting one side of the body, that might also make you think perhaps it's a demyelinating disease. Maybe we're seeing like an MS or something like that. The headache, not really consistent with that. And then the unresponsive to even deep pain, so that the coma that he gets into and the unresponsiveness to deep pain shouldn't be affected by demyelination. Demyelination is only going to affect the myelinated fibers, and pain fibers, for at least the C fibers, are myelinated. Blown pupil is going to cue us into the next one, but probably what we're dealing with is brain tumor. Stroke would be more likely if the symptoms came on very quickly, and then rather than getting worse, they got a little bit better as the stroke resolved. So after the initial swelling that occurs, for example, and the restoration of blood flow. So stroke, we'd see the opposite, acute onset and getting a little bit better, but here what we're seeing is gradual decline in function. So I wouldn't think stroke here. And we don't have infection. I would be thinking brain tumor because he's old. All right, the patient's old. In an old patient, it's cancer until proven otherwise. So unless they have like a history of stroke in their family and the signs seem like that, or they have maybe some heart problems that would be more suggestive of stroke, I'd be thinking tumor. Which brain region? I hope we got this one. Okay, good. Most of us are getting midbrain. Now, it can't be medulla because we're hitting the same side of the face and the body. We'll get into this later, but there's the crossing of fibers. And if we have time, I'll circle back to it. The one that makes the most sense is midbrain. What's jumping out to you as being midbrain?
The pupil.
The pupil, exactly. The pupil, the unresponsiveness, but the pupil most definitely. That's cueing us in. This has got to be midbrain. And indeed it was. All righty. We have ourselves another case. We have a 64-year-old man who developed right hand weakness following cardiac arrest. The patient had a history of hypertension and cigarette use. He collapsed suddenly in church. Let's see, they administered CPR and a little electric defibrillation. He had normal cardiac rhythm after that. Then he was admitted to the cardiac ICU, had episodes of rapid atrial fibrillation. Several days later, he was noted to have weakness. So we had a bunch of cardiac events. Then we have weakness in the right hand. Mental status was normal, cranial nerves normal, sensory normal, reflexes normal, motor function basically normal, except for that right hand weakness. So the grip, the fingers, and at the wrist, so the hand. Now we want to think about where is the lesion and what's causing it. We have another case below that. Again, older man, woke up one morning. Here he had a blistering rash. Here's where the rash is. Along the same area of that rash, we have weakness and numbness. Now the patient had type 2 diabetes that he managed with insulin. Vital signs were all normal, heart disease, no history of that. Other than the blisters and this and the diabetes, everything was pretty normal. So we're seeing reduced deltoid strength. I think that's somewhere around here. Whatever the hell, I guess external rotation would probably be this. Tell me if I'm wrong, I probably am. Biceps, what the hell is a brachioradialis? Can anyone, if we can get Dylan up front, I think he'd probably be the best for this.
That's your drinking muscle.
My what?
Your drinking muscle. You go like this. That's the muscle you're using.
Oh, this right here.
No, it runs right here. And
Uh-huh.
when you're set up, like you're holding a can and you drink the can or a mason jar and you drink out of it, that's the muscle you're using.
How's that different from my biceps?
Well, because your bicep is like your palm is going to like hit your face.
Uh-huh.
But your brachioradialis is when your palm is facing this way and your thumb is going to hit your face.
Oh.
It's like the
Oh,
hammer
okay. I
curl
didn't realize
muscle.
there were multiple muscles in there.
Yeah.
Alrighty. So he had a little weakness in his. Let's see, the reflexes were absent on the left, biceps and brachioradialis. I guess that's in here. Thank you. Other reflexes, 2+. We have decreased pinprick sensation in the area of the rash. Okay, so weakness and decreased sensation in this area along with a rash. Reduced reflexes or absent, I guess. You should be thinking, what does that sound like? What kind of weakness? Upper motor neuron, lower motor neuron. All right, that'll help cue us in. All right, we're in the 30s, so we'll go ahead and take a look here. So where is this first lesion? So we have weakness in the hand. I want you to think about, is this following a myotome? Or is this more restricted to a body part? So think about the map that exists in our brain versus our spinal cord. So myotome is going to kind of run along bands of skin, whereas the functional areas in our cortex are going to be organized around body areas. So if we're going to have hand weakness, and it's not following a myotome, I'm not giving you the option of specific peripheral nerves and maybe damage over here. That doesn't make sense anyway. This has got to be up in the brain. So we're affecting the right hand. It's got to be the left precentral gyrus. Upper motor neuron, not lower motor neuron. And the reason that we're not thinking that is because we're not seeing myotomes being followed here. And we also want to think about what's probably causing this. Well, I guess we should see your answers. Okay, great. Yeah, most of us, we're looking at a stroke here because he had cardiac issues. We probably had clot formation. And then that got sent on up into the brain and caused damage in the left hand region, or the left motor cortex, so for the right hand. Now, if we go on to B there, let's think about this pattern. That is following that of a dermatome. And we're seeing weakness that's consistent with myotomes. So we're following that kind of a radial pattern that we would expect if we have damage down in the spinal cord. So we're hitting the left side. At this point, we're already crossed, so hopefully we're hitting the left spinal cord. Nice. Now, some of you might be thinking diabetic neuropathy. Okay, good. That's the second most commonly picked one here. Now, diabetic neuropathy should not cause these patches. Why the hell are these two? All right, anyway. The patches that we're seeing here is telling us we probably have some sort of infection. This sounds a lot like shingles, so viral infection. If it was diabetic neuropathy, stocking and glove is what we should be seeing there. Stocking and glove distribution. All righty, this case is just a picture. This should be pretty easy. This one on the left, what plane are we in? What's the plane on the right? And where is this hemorrhage? Finally, what could be going wrong, right? We got a bunch of possibilities. We got because it's in the cerebellum, hopefully we're thinking about movement, but there's other things that can come up. We'll just run through this one before we get too many in. And these are going to be up on the website. They'll give feedback. You can go through these anytime. When we don't have a slideshow and we're together in person, I want to spend a lot more time working through these. So left, again, axial, horizontal, just like we've seen before. That one on the right should be parasagittal. Let's hopefully all land in the cerebellum. Okay, all right. So this one should be a dead giveaway though. The misfires on that one are a little questionable. So hopefully we can all see the brainstem here, thalamus right on top, clearly the cortex, down below the cortex behind the brainstem, cerebellum, the little brain. That should be pretty obvious to us. The options here, man, it could be a lot of things. We better not include vision though, because vision isn't going to hit the cerebellum. That's going to go from the eyeballs to the thalamus. We're never going down below. drowsiness is an option, especially when you're looking at this hemorrhage, because it kind of looks like we might be pressing forward on the brainstem there. So we might expect a little more drowsiness here. But you can also get drowsiness and fatigue in cases of cerebrospinal ataxia, so neurodegeneration of the cerebellum. So drowsiness is something you might expect when you have cerebellar damage. Most definitely gait and stance instability. This is a big one for sure. Nausea and vomiting, always an option whenever you have a hemorrhage, especially whenever you have it down in the brainstem. Cerebellum is going to affect our vestibular system, and when you have vestibular damage, you can definitely expect to see some nausea and vomiting. In the slurred speech, that just has to do with improper coordination. We shouldn't see any change in sensation, though. It's possible because of the growth or the size of the hemorrhage, but not the principal one that we want to see there. All right, last one. We got a young guy here, 19 years old, had a rapid increase in height over the last 2 years. He had a head injury, went in and got a CT scan. He didn't have any neurological signs, but they did see a calcified mass in the interseptal region. If you don't want to Google that, it's right above the hypothalamus. So there's your answer. On admission, he was 2 standard deviations above the mean for Japanese males. And his weight was 75 kilograms, so he's a big dude. We might think that there's some sort of abnormality with growth hormone. Indeed, there is. So look at table 1. Growth hormone is well outside the normal range. So what we're seeing are neuroendocrine abnormalities. And because of that, he had notable growth in the past 2 years, long fingers, and he had that glabellar protrusion, so kind of the sloping forehead, it's sometimes described as. So a protrusion right here. This is typical whenever you see high levels of growth hormone. So you're going to see a lot of growth. So CT scan showing a calcified mass, we should be thinking brain tumor. Most likely place, of course, hypothalamus. Why else would I give you a bunch of neuroendocrine stuff? So hypothalamus, pituitary, both were probably affected here. So that tumor in the interseptal region is probably affecting the communication between hypothalamus and the pituitary, leading to an increased output of growth hormone, which explains the precipitous growth over the last 2 years. They removed it surgically, and after treatment, he goes back to the normal range for growth hormone. So everyone lived happily ever after. And no one thought anything but hypothalamus there. Great. Calcified mass, I wouldn't expect with the hematoma. The keyword there, calcified mass. Alrighty, we're 3 minutes early. How nice is that? Are there any questions before we wrap this up?
Yeah, I have kind of a dumb one. When you have medical imaging up on these slides, like a couple times you said like, oh, this is after they put a catheter in. Is there a way for us to know if like something is before and after versus like 2 different images on different levels?
Yeah. So hopefully I'm going to write that in the description.
Okay.
Like panel D here is the CT at 1 month follow-up.
Okay.
Let me make sure it had it over here. I try to do that because if you don't know, it would be impossible to.
Okay, I'm just making sure that I'm not supposed to be able to tell.
No, you will have no way of knowing unless I tell you. So like right here in panel B, the left is before and the right is after placement. And you can actually see the catheter right there.
I would not have picked that up, so.
So definitely read the description of the images. That'll help a ton. And I'll always put that in there. You would not be able to know.
Thanks a
Good
bunch.
question. Certainly not as stupid of a question as how do you enable a breakout room? So don't feel bad.
I don't know.
But hopefully we won't need them. You guys will be here next week. And hopefully you stick around. Any other questions?
I don't know if this is just a me thing, but I know when I was like answering the questions for the different cases, sometimes I would look at the like outcome and like it, like some things it said in it would kind of lead me towards what my answers would be. Is there a way that like, and if nobody else feels this way, it's fine, but that we could see like the outcome after you already submit the answers to the questions or something like that?
I can do that. And I went back and forth on whether or not I should put that at the end or include it here. So I can move all those so that after you submit, it'll, rather than saying thank you for your response, it'll say what happened.
Had you initially put them up as like assistance in the case report? If like you hadn't picked it up already, knowing that this was the way that it resolved, you were able to come to your answer, or were you just putting it down there so that we knew it kind of happened?
I put it down there because I don't really see that screen at the end for the submission. And this way I could just see it. And I tried to take information out that would give too much of a hint. And I wanted to, in at least most of these cases, not, I wanted to make sure it wasn't a bummer. But I guess if it comes up at the end, then it's okay. And I changed them and then I changed them back. So I can redo it. It's no problem. So I'm going to plan on doing that. And if you find that it's not an improvement or it's worse, just let me know. But yeah, I'll take the outcome and get it off of here. It'll be at the end. So you will know what happened if I know what happened after you submit. Any other questions or comments? All right, cool. Well, we'll call that a class then. I'll see half of you tomorrow on Zoom. And I'll know how to do a breakout room by then, I'm sure. And I'll see the other half of you on Wednesday. So we'll be going through lecture one.
I think we decided that we were all gonna do like
God
Wednesday
damn
and
it.
Friday.
Yeah, Monday, Wednesday, Friday. Yeah. Totally true. You know what? If I don't change my calendar, I'm going to think that that's there. Thank you. Okay, so I'll see all of you on Wednesday. And I'll see all of you on Friday. And we will go through lectures 1 and 2. So we'll go over nerve cells and we'll go over development. And then I'll see all of you in person next week, not on Monday. We have, wait, is it Monday? Do we have class next Monday?
No.
No.
Okay, good. It's not on my calendar. But then I thought, yeah, I might have just fucked that up. Okay, so I won't see you on Monday. I'll see you in person, split in half next week. Okay, have I messed anything up in this exit? All right, I'm going to continue to trip over myself then and end this. I will see you Wednesday. So long. Okay.